Hello and good evening. I'm Adrian James. I'm the President-elect of the Royal College of Psychiatrists, and I'll be chairing this college-wide live webinar on COVID-19 impact on Black, Asian and minority ethnic communities. Thank you for joining us. We've got nearly 1,000 people signed up to this webinar. There'll be an opportunity for you to ask questions of myself and of the speakers at the end of the presentations. On the screen in front of you, there's a Q&A panel. Please post your questions there, and we'll bring those together and ask the questions towards the end. We'd like to confine the questions to the topic under consideration today because it's so important. But if you have more general questions about COVID-19, on the college's website, where you've got all the information about COVID, there's a Q&A, ask a question panel. So if you want to post questions there about anything to do with COVID, then please do. If you'd like to tweet, we'd very much welcome it. And if you use the hashtag RCPsych live. I just want to say a couple of things before I pass on to our speakers. I want to welcome you and thank you for all you're doing, for your patience, for the college, and whatever organisation that you work in sort of academic institutions as well. I hope that you will all take the time to look after yourselves and each other and to check out with each other how you are, particularly those who are shielding and are working remotely. I'd really like to encourage you to undertake our regular members survey. This comes out every 2 weeks. It does include questions around the impact on Black, Asian and minority ethnic members. So it's really important. And also the coronerve surveillance, which was the subject of our last webinar. So this is really tracking the direct neurological and psychiatric impact of COVID-19. I'd like to draw your attention to the college statement on the appalling killing of George Floyd and our general statement condemning racism in all its forms. The scenes that were shown were utterly shocking, and but it's important that we actually don't just look at police brutality, that we look at racism in all its forms. And this has been one of my priorities before any of this arose, that we actually as a college, we take a really thorough look at it to get our own act in order, but also within the whole mental health community. And of course, the impact of COVID-19 on Black, Asian and minority ethnic members and our patients has been very stark and very clear. But all that COVID-19 has done is to shine a light on something which is there in many, many forms and affects health and mental health and people's lives generally. And it's important that we take wider lessons and we extrapolate from this to actually look at it in all its forms. So I'm determined to do that, and it is one of my stated priorities. So now I'd like to pass on to our speakers. We've got 3 excellent speakers, and our first is Professor Dinesh Bhugra. Dinesh was the Dean of the College, President of the BMA and President of the World Psychiatric Association. And he's also Emeritus Professor of Mental Health and Cultural Diversity at King's College. So there can be nobody better globally to kick us off with this topic. So over to you, Dinesh.
Thanks very much, Adrian. Good afternoon, everyone. I'm delighted to be here, and I'm going to be doing 3 things in the next 10-12 minutes. Firstly, give you some definitions of ethnicity, race, culture, racism, and then present some very interesting data on COVID and ethnicities. And lastly, we're going to try and look at what we need to be doing as a profession to take things forward. Next slide, please. First and foremost, if we look at ethnicity, and it is defined as an individual who belongs to a group with common ancestry and similar physical and cultural attributes, for example, physical features, rituals, norms, language, etc. It is self-ascribed, and I think that's very, very important to bear in mind. It is how an individual sees himself or herself, and has to be differentiated from nationality, which refers to a political community which shares common origin or common descent. Next slide, please. Race is a term which has been used in two ways. Firstly, as a biological one, and secondly, as sociocultural. The idea of race is not new, certainly in terms of British colonialism, and when anthropologists traveled around, went to the colonies and saw the natives, so there was a clear distinction between what a native should look like and what the rulers should look like. However, I mean, it's really quite fascinating that in 4th century BC, when Cicero was representing Emperor of Rome in UK and Great Britain, he wrote back to the emperor saying, do not employ slaves from Britain because they are lazy and indolent. So this creation of racism, I think, is quite an important aspect. It's partly about power, it's partly about rights, but more importantly, it is about creating the other. I am who I am because you are someone else. And that kind of, in a superficial way, focuses on biological differences, which focus on physical and genetic qualities such as hair color, color of eyes, skin color, hair texture, etc. And sociocultural definitions relate to geographical migration. Next slide, please. So that looks at characteristics, values, and behaviors which are associated with physical characteristics, which again, as I said, kind of serve the purpose of providing a way for outsiders to view another group and how members of that group see themselves. And part of the challenge really is that when we look at groups of individuals, it is to do with we stereotype people that, you know, all Britishers behave like there's a stiff upper lip, or all Germans are efficient. And so partly it's about national characteristics, which are used as stereotypes in order to partly take a shortcut into identifying the other. And partly it is about identifying those characteristics which give people an opportunity of sort of obtaining power. And racial groups are not genetically discrete. They cannot be measured reliably and are certainly not meaningful. And they feed into racism, particularly institutional racism, and it's about power and privileges. And I'll come back to that a bit later on, because I think it is crucial that when we look at mental health services and we look at the responses of various ethnic groups, migrant groups, and the other, whether they are South Asian, African Caribbean, or East European, those stereotypes carry on to play a major role in terms of how they are seen, how they're treated, how they are dealt with, both therapeutically and in terms of mental health assessments. Next slide, please. And culture, on the other hand, is a configuration of learned behaviors, which results which has values which are shared and transmitted by members of a particular society. We are not born with a culture, we are born into a culture, and we learn. Our culture affects the way we see the world, our worldview. Culture also focuses very much on our cognitive and social development. And again, from a mental health psychiatric services perspective, we need to be very careful that things like cognitive behavior therapy do not work in the same way across different ethnic groups, because the idea of cognitions is very, very culturally influenced. It's also been defined as a collective programming of mind, which distinguishes one category of people from another. It's a set of distinctive spiritual, material, intellectual, and emotional features of a society or a social group which encompasses art, literature, laws, lifestyles, value systems, traditions, and beliefs. Next slide, please. And we know, and I'm not going to go through, it's fairly well established that rates of various psychiatric disorders are high in some Black and minority ethnic groups, not only in the UK, but also from various countries in Europe. Rates of schizophrenia in African Caribbeans in the UK, rates of schizophrenia in Guyanese migrants in the Netherlands, etc. Rates of deliberate self-harm in second-generation South Asians were shown to be high, but that's now beginning to change. Over 30 years ago, when we did a series of studies in Southall and West London, these rates were very high, but about 5 years ago, a similar study done showed that the rates of self-harm were beginning to shoot up in Black women. So there is a very clear shift, which may be because of cultures in transition, which may be because of other factors. And we know that depression among Bangladeshis and Pakistan heritage individuals is high. And we're only now beginning to look at rates of psychiatric disorders in other migrants. We had previously looked at rates among Irish migrants, but now we're sort of looking at East European migrants and how that impacts. Next slide, please. Next slide, please. I think we lost it somewhere. We know that these variations in rates have been attributed to a number of social factors which vary from social determinants as well as psychological determinants. And what that does is that quite often it can lead to, particularly in psychiatric disorders, sometimes overdiagnosis, sometimes misdiagnosis, sometimes underdiagnosis, because people do not want to look at disorders in a way that makes them feel unmanageable. So there is also that quite a lot of evidence that racial life events, unemployment, discrepancy between aspiration and achievement also play a role. Next slide, please. I think we may have given up on slides here. I do apologize. But we also know that the help seeking is delayed due to stereotypes. We just assume that South Asians would look after their own. South Asians may feel a sense of shame in seeking help, a stigma, and when they reach psychiatric services, they may feel that they're being treated like some unknown individual quality. So there is a degree of institutional racism. For example, that you may not get the food that you want or material for makeup, etc. So the stereotypes are quite important, because particularly in terms of if you're looking at the COVID rates, and I just come back to that because both Abdul and Ananta are better placed in commenting on that. But I just want to highlight that there are stereotypes that, as I said earlier, that South Asians look after their own. All South Asians live in overcrowded settings, which is not true. And it's partly related to unemployment. And we know that in certain ethnic groups within South Asian groups, unemployment rates are actually much lower than the white population and otherwise. Next slide, please. And we know that there are higher rates of diabetes mellitus in Black and minority ethnic groups, higher rates of hypertension, higher levels of obesity, as well as other physical illnesses such as osteoarthritis, arthritis, chronic obstructive pulmonary disease, etc. Next slide, please. So we know the institutional racism persists. I mean, we've seen it in the time of lockdown. Blacks are twice more likely to have been stopped during the lockdown than white people. They're also less likely to be listened to if they are whistleblowing in hospitals. And if we include Filipinos and East Europeans as minority ethnic groups, they're much more likely to be low-paid frontline and care home staff, which means that they're much more prone to be exposed to the virus. Next slide, please. Very rapidly, just to say that these are the findings from a report from Association of Local Authority Medical Advisors group, that rates of death are 1.5 times among Asians compared to the white population, 1.7 among blacks, and similar figures in mixed and others non-white. Next slide, please. And again, BMI, so as your BMI increases, the rates go up. So if it is between 30 and 34.9, you're 1.4 times more likely. But if it is over 40, you're more than 2.4 times likely. Next slide, please. And similarly, if you've got diabetes, the kind of rates vary between 1.5 if you have type 2 diabetes to 3.3 if your HbA1c is unknown. Next slide, please. And it is that what they've done is they looked at the number of added years of age. So if you are Asian and you have COVID, then it adds 4 years to your age. But for blacks, it's 6 years. For mixed, it's 5. And for others, it's 3. Next slide, please. And again, so, if your BMI is over 40, then it adds 10 years. Next slide, please. And again, between 4 and 13 years, if you've got diabetes, so that many number of years, it adds to your life. Next slide, please. So the other number of issues that we need to be thinking about, that it is not only psychiatric disorders which are higher, there is also rates of infectious diseases. But what is really important and worth bearing in mind is that in many ethnic groups, after migration, changes in lifestyle and changes in diet produce a difference in the rates of various disorders. There were a series of fascinating studies done in the USA where they followed up Japanese women who had migrated from Japan. Rates of breast cancer in Japan used to be very low, whereas they were relatively high among American women. but longer the Japanese women lived in the USA, and subsequent generations, the rates started to increase. So there is something else that's going on. It's not purely genetic. It's obviously something environmental, something in lifestyle, something in diet. And we know that for a lot of individuals, there is going to be use of complementary medicine and smoking, etc., and that may be interacting with various other factors which play a role. And I am seriously disappointed with the PHE report which came out yesterday, that they just presented a whole host of data and they've not tried to look at the potential explanations. And it is without those potential explanations, it's very difficult to know what needs to be done and how we do it. Next slide, please. So just to remind ourselves, just to conclude, that ethnicity is extremely relevant in incidence, prevalence, and outcome of mental illnesses, as well as physical illnesses. It adds to the contribution to comorbidities. And what we need to be thinking about is culturally sensitive and culturally appropriate interventions, which is partly about cultural competence, but it is basic good clinical practice to look at the person who's sitting in front of you, to try and make sure that their needs are met within the context of their ethnicity and culture. Thank you all very much.
Well, thank you, Dinesh, for setting the scene so comprehensively. Let's move on to Dr. Abdul Razaq. Abdul has formerly held positions as Director of Public Health for 15 years. He is currently consultant in public health at Lancashire County Council and visiting senior fellow at the University of Suffolk. He's got a great deal of expertise in this area. So Abdul, over to you.
Thank you so much, really, Adrian. And it's a pleasure to actually join this webinar. First slide, please. My presentation this afternoon is focused primarily on two aspects, following on from Dinesh's excellent initial salvo. As a result of some work that I was doing within the Lancashire footprint with local communities, we soon came to actually realise the disproportionate effect that COVID-19 and SARS-CoV-2, the virus, was actually having on ethnic minority and BME communities. And that data and intelligence was actually coming directly from communities themselves, who provided really the first signal around the disproportionate effect. And as a result of that, clearly we also actually had some intelligence immediately coming in from our funeral directors, where I was actually doing some work in relation to preparing them really for the deaths management kind of perspective. So my presentation will focus on our rapid review, which was actually completed at the in terms of timeline towards the back end of April of this year and early into May, over a period of approximately 4 to 5 days, and which was published at the University of Oxford with their Centre of Evidence-Based Medicine. So this was a review carried out with Directors of Public Health and with academic partners. Next slide, please. So as this evidence was actually emerging during this period of time, there were some, as I said, some anecdotal reports clearly which were providing a clear signal around disproportionality around BME and COVID. We know that BME communities actually make 14% of the population, although the census information clearly is now almost 10 years out of date, and we have newly arrived populations within our shores. We know that BME doctors in particular make up 44% of all NHS doctors, but at that time, according to the Health Service Journal analyses, which was carried out and published on the 22nd of April this year, 95% of all deaths So clearly alarm bells were ringing at the outset, really, at that period of time. And clearly we're finding them their way into the media. BME nurses make 20% of all NHS nurses, but 71% of all deaths was the initial finding from the HSJ analysis. And clearly these areas really, we were also seeing a disproportionate effect by geography. We were actually finding really that those the London boroughs, in particular Newham, Harrow and Brent, were actually finding high levels of excess deaths within those communities. Next slide, please. Subsequent to the publication of our rapid review on the 5th of May of this year, there was a subsequent analysis carried out by the Office of National Statistics, which you actually may be aware of, where it was actually shown really in terms of the full model analysis and the taking away of some of the confounding factors, that Black people were 1.9 times more likely to actually die of COVID-19, and whereas Bangladeshi and Pakistani men are 1.8 and women 1.6 times as likely to actually die from COVID. So we could see really that our initial findings really around vulnerability and risk was clearly being was not an anomaly. There was a building of the picture around the signal that we initially actually received. Next slide, please. In tandem with that, there was another source of information from hospital and GP records. So the Open Safely study used 17 million records and was published on the 7th of May, 2 days after our rapid review. And this controls for a host of socioeconomic factors, health risk factors and comorbidities. Ethnicity was independent of similar magnitude to ONS data after the actual controls. And what this found was Black people 1.7 more likely, and Asian people 1.6 times more likely to actually die than the white Caucasian population after all those factors were taken into account. Next slide, please. So what is this actually then? How do we actually break down and segment some of this into a structure that we can actually start to actually dissect? I know that Dinesh, you mentioned the PHE report that was just published this week. Unlike the PHE report, which is data and talks about risk around disparities and outcomes, we did do a comprehensive literature review and go into some of the causal factors which may actually be plausible explanations for the disproportionate effect that we were actually seeing through these signals. So the first element that I want to describe here really is the number of cases. So within this framework, really, we were talking really primarily about exposures, the exposure of the virus in terms of these aspects. So the first aspect really is about exposure of the virus for employment in terms of the NHS, the other occupations which are high risk in terms of precarious or 0 hours contracts, frontline jobs. The second element clearly was due to living conditions. We know that although not all ethnic minority communities actually live within multi-generational households and high density, a lot of them actually do. So therefore, that could potentially actually be a plausible explanation around exposure risk. The further aspect clearly that warrants attention and further investigation through research is around the effectiveness and design and communication of public health advice around appropriate cultural messaging, whereas all the guidance clearly is in English as to whether those populations with basic or literacy needs clearly understood the comprehensiveness of the message that the government and other bodies were actually giving them. The other aspect clearly around exposure is about inadequate testing and tracing, which clearly has now actually started, and I'll come on to that towards the latter part of my presentation. So all of these factors combined, really, it was our initial view would actually mean it would actually be harder for BME populations to actually successfully lock down, and therefore there would actually be a higher reproduction number, the R number, as it's actually been described. And so there we would actually see more cases, even if severity and treatment are the same, would actually result therefore in more deaths. Next slide, please. The second element that we actually describe really is severity of cases. So the increased severity really due to comorbidities, cardiovascular diabetes, and Dinesh has actually covered that very, very well through the study he actually cites. So the and clearly in terms of a potential causal factor, and that has actually been well cited and documented within a range of studies, including the ICNARC, the intensive care data, around the complex comorbidities and ethnicity issues in terms of a multivariate analyses. The increased severity could also be due to the overcrowded housing, resulting in a higher viral load. It could also be associated potentially with poor air quality in terms of areas of deprivation. We know that the communities tend to actually live within more deprived and challenged areas with poor air quality and other environmental factors. So that's obviously warrants some further attention. More severe cases really result clearly, if equal numbers of cases, unequal treatment will result actually in more deaths. Next slide, please. Another element clearly is about the whole element of treatment in terms of the access and the entry points into services around the treatment of cases. Clearly, one of the issues to explore is either conscious or unconscious bias within as part of that entry into the actual system, leading to potentially suboptimal advice and treatment pathways. Worse treatment by ambulance service, clearly leading to later hospitalisation. Could that be a potential reason, or is it really that there was a reluctance on the part of BME communities to actually admit themselves, considering that in terms of what they knew in terms of their other intelligence or what's actually happening on COVID wards. I certainly know really anecdotally and otherwise that some families actually made an informed decision around their loved one to keep them at home in terms of palliative and end-of-life care, rather than actually committing those individuals and their loved ones to a hospital environment, for example. So worse treatment by hospitals leading to poorer treatment choices such as DNR, and clearly all of this would actually potentially result in more deaths. Next slide, please. So this really kind of cements some of our thinking within our rapid review into breaking this down into sort of concepts and plausible reasons into structural versus individual factors in its simplistic form. So more frontline roles clearly was one of our findings in terms of, and then the uptick of the advice versus cultural differences that would actually result in increased isolation and adverse effects. The impact really of higher allostatic load. So in terms of the already impacts really of the individual in terms of societal impacts, in terms of racism, discrimination, and everything else really in terms of biological inequalities, clearly was that a potential actual factor. And I know there have been some studies in London in particular looking at this very issue versus vitamin D deficiency in terms of what we know around vitamin D is that NHS UK and Public Health England revised their advice nationally in terms of vitamin D deficiency. And what we know clearly is even pre-COVID, a lot of our communities really are insufficient in vitamin D, which has clearly a very important role in terms of respiratory health, but also in terms of immune response. There are some randomized control trials actually taking place around vitamin D in particular, and there are some studies from intensive care and hospital settings overseas which indicate a role of vitamin D in terms of BME COVID deaths. But there's further work really in relation to that. In terms of access, moving on, there's clearly an issue around utilisation of healthcare resources during the pandemic of BME communities. Was this a particular factor? And clearly what we found clearly is that there's probably a mixture of causes, and clearly trying to dissect, what was the predominant ones versus the ones that clearly, in terms of confounding factors, clearly was something really that we were not able to do in detail, but we clearly described these were the areas really that the Public Health England review and further NIHR research around BME COVID deaths should actually consider in full detail. So how do we actually unpick all these causal effects from this observational data is something really that is the ongoing debate in terms of the live discussion and obviously the Q&A, which we'll have later on. Next slide, please. As part of my rapid review, I came up with a vulnerability framework, and this is what you see in this slide here. I was trying to conceptualize here really on one side, really, as you can actually see on the left-hand side, the BME population actually segmented versus a model really around exposure risk, and then clearly trying to actually articulate wherever possible the vulnerability of BME communities. So across the top you can actually see community exposure risk, followed by comorbidity condition risk, which is existing comorbidities that BME populations actually have higher preponderance of in terms of their incidence and prevalence, and then clearly moving on to disease severity as to whether that goes on to actually manifest themselves in terms of adverse and increased disease severity risk, and then moving on in terms of health and care setting exposure of the actual virus. Clearly PPE was a live issue at that time and still is. Within settings, clearly were there a number of factors in relation to the actual settings themselves which actually contributed towards higher exposure risk and vulnerabilities, and ultimately in terms of an outcome, an adverse outcome, clearly in terms of death risk. So I find this immensely helpful to conceptualize by population group rather than actually having looking at it from a lens of the BME communities, to actually segment those down into the various component parts in terms of whether they were, what age they were, whether they're shielded or not, whether they clearly lived in multi-generational households, and whether they had long-term conditions, and so on and so forth, or whether they were actually healthy, in terms of that sub-segmentation, to be able to then categorize and look at the risk profile really for our BME populations. And I know that this framework is being used and has been a cursor really for some of the scoring tools which have actually been later developed. Next slide, please. In tandem with this, as we were going through the COVID pandemic and the outbreak at that point in time, there was a real focus not only on describing and actually carrying out the rapid review, but with one of the key authors of the rapid review, Professor Kamlesh Kunti, we were asked by NHS England to set up an expert advisory group to advise NHS England in terms of the disproportionate effect on health and care workers. And we did this piece of work really over a very short space of time, really, by bringing in colleagues from NHS employers, from the Faculty of Occupational Medicine and public health experts, and we developed what is now known as the risk assessment framework for health and care staff. This is now well recognised as a framework tool. And clearly there have been subsequent versions, including the Wales version. There is a primary care version as well, and there are other models really actually being developed within education settings and care settings, building upon the original framework that we developed, as you can actually see in this slide. It has three component parts in terms of a workforce assessment, a workplace assessment, and an individual assessment. And clearly BME and ethnicity is one key component part, and it's kind of evidence-based in terms of the age profile and the conditions and so on and so forth. So clearly, if you've not seen that, then please do go on to either the Faculty of Occupational Medicine website or the NHS Employees website, where it's readily available. Next slide, please. So I believe in the absence of key recommendations flowing from the Public Health England report, that these are the immediate research questions that need addressing within our community together. And the first one of those really is, what interventions exist to actually help mitigate these impacts in the immediate term? As I said, really on a recent conversation with other colleagues, we did not wait really for the recommendations, and I don't think we can actually wait for the recommendations of government to actually come forward. We have a duty of care to our respective patients and to our residents and our communities. So therefore, I think under these precedent circumstances, we need to actually take appropriate and action. Whilst a lot of this evidence and research and recommendations actually then flow through in due course. Secondly, is it possible to actually unpick those causal effects due to individual and structural using the actual data? Hard, but clearly there are some clear signals around the things that I've just described. What does this response, thirdly, to the disease in both clinical terms and economic terms tell us about the implicit valuation of different lives in terms of what we're actually seeing in terms of Black Lives Matter, and obviously some of the scenes that we're actually seeing across the globe in terms of people actually being appalled clearly about the death in America. The fourth, do people actually voluntarily take uncompensated risks, or are power dynamics part of that in terms of economic studies? And clearly, you know, what is the role really of epidemiological and economic analysis within all of this in terms of policy? So there's lots of work, lots of networks that we've established as a result of this. We've built a framework, and a skeletal framework, and a network of individuals who are now actively working on some of these questions, which I think we didn't have towards the start of the outbreak. Next slide, please. This is my final slide, and clearly this is, as I describe really, this is in terms of the actual next steps. I believe that there are, not only is there one a pandemic across the globe, I believe currently in 2020 there are at least 4 contagions taking place. And the key issues for us collectively as a society and as a Royal College and elsewhere really is to actually address and to describe and mobilise to address these 4 contagions of 2020. The first contagion is a well-known contagion, and that is the contagion of inequalities. So Michael Marmot actually published his 10 years on report in February of this year, and clearly we're still waiting to actually take some further action in relation to that. And then COVID clearly arrived on the scene. So that's clear. The inequalities agenda is pivotal in terms of tackling the social determinants of health and the levelling up agenda across the political divide. The second contagion clearly is the pandemic. We have to beat this virus, and we will successfully together, but not without its huge amount of human suffering and loss. The third contagion clearly is one of racism. Now, this is an ever-evolving journey. Having been in public health for approximately 30 years and clearly having worked on this agenda around ethnicity and BME, this is a fight clearly which goes back several hundred years around equality and human rights. And clearly, you know, the fight and the journey continues. And finally, we have a contagion of anger linked to mental health and well-being. The emotion and the overwhelming response of communities breaking social distancing rules, which clearly is a concern from a public health perspective, but the outpouring of emotion around the scenes from America clearly are something really that we need to be cognizant of. How do we actually then manage that process as a society in terms of peace and reconciliation? And that's it really for me. Thank you.
Thank you, Abdul, for taking us through the structural and individual factors as well as the vulnerability framework. We are going to extend this webinar by 5 minutes because we've got such good presentations. We want some time for questions, but we're going to move on now rapidly to Dr. Ananta Dave, Ananta is Medical Director and Consultant Child and Adolescent Psychiatrist at Lincolnshire Partnership NHS Foundation Trust. And Ananta chaired the Task and Finish group on the impact of COVID-19 on Black, Asian and minority ethnic staff. So Ananta, share your findings with us. Thank you.
Thank you. Thank you very much, Adrian. And thank you for inviting me to be a part of this webinar today. Very topical and very important. And following on from the two very powerful presentations, setting the context, the understanding of culture and racism, and looking at some of the factors which might lead to increased deaths in Black, Asian, and minority ethnic staff due to COVID. I'm going to try and set out the context as to what we can do. I think so we know the data, we know the context. I'm trying to see what it is that we can do from a mental health care perspective. How can we respond as organizations, as provider organizations, as well as the Royal College? And therefore, I'll just try and pick out points from the report, which I worked with as part of an excellent team at the Royal College. And pick up some key points from the report, but also then move on to some recommendations or suggestions for a way forward as to how do we respond to this. So next slide, please. So I just want us to take a moment to pause and feel. I mean, Abdul's presentation at the end really brought out the emotion that we are feeling at the moment. And I welcome the explicit statement made by the Royal College about the appalling killing of George Floyd in the US, and also how it actually means that we should be shining an unflinching light on ourselves in the UK as to how we respond to racism, how we tackle institutional racism and inequalities and inequities, and how it relates to mental health care and the outcomes within mental health care. So really a moment to pause, remember, and regroup, and focus our energies into seeing what it is that we can do, because Black lives matter and every life matters regardless of their origins or where they come from. And I'm glad that we are talking about this openly in a college webinar, because staying silent is not an option. And injustice anywhere, whether it is in another country, whether it is in mental health care, public health, it means that when we tolerate that, we tolerate it elsewhere. And also one very important point is those of us who provide mental health care, who look after mental health patients, and who work, know that they can be a stigmatized group in themselves. So how we look after staff in mental health care says a lot about how much we value mental health care services, the patients who need them, and ultimately about the sustainability of those services. So really important that we get that right. Next slide, please. So the report that we produced on the 13th of May after the Task and Finish group met is really, I see that as a starting point. So I hope people have had a chance to look at the report. There's the link. So I won't be going into the details, but it does, what we tried to do was to give some guidance and an outline so that organizations across all the developed nations in the UK, in the publicly funded and independent sector, could actually look at how they could take a systemic organizational approach to supporting staff, because by supporting those most at risk, we support everyone. And we wanted to say to organizations that this is something that should be acknowledged at the highest level within each and every organization, at a provider organization, so that the right steps can be taken. It can be, visible and transparent to everybody as to what's being done, and it can be reviewed regularly. So I see it as a task and start group. It's a starting point, and the question now is, where do we go next? Next slide, please. So just to put it in context, the HSJ article that's been referred to, the 22nd of April, but also the follow-on article on the 19th of May, talks about around 11% of individuals who had died due to COVID working in a mental health care setting, and mental health care staff account for around 18% of NHS staff as a whole. So some of the data we have available is in relation to England, but clearly applicable across all the devolved nations, but just gives some sense of what percentage of staff we're talking about. And we know that 94% of doctors and around 2/3 of nurses and other health professionals belong to a Black, Asian, minority, ethnic, or a BAME background. And in terms of the Royal College membership, 39% are from a BAME background, and the doctors registered on the GMC register, which are all doctors, 33% are from a BAME background. Next slide, please. So what we said in the report, what we wanted to in the report is that not only is it important to say things as they are, to explicitly problem is, but also say it in a manner which is collaborative, inclusive, and which makes people want to open up rather than blaming. So it is about working through the problems together and learning together. So some things to keep in mind is it has been the word BAME, or the acronym BAME is used, but clearly it does not mean a homogeneous group of people, and it's really important for us to keep the person in mind at all times, the individual with their unique identity and story, whether it is a staff member, whether it's a patient. So it refers to a range of ethnic identities and entities, and we really need to keep that in mind and need to understand each person's story. And also language matters, because inadvertently or unintentionally, we can actually perhaps exclude or make people feel othered when we use certain terms. I mean, I'm just being honest. When I look at the term underlying health conditions, it does make me feel as if they're all grouped into one condition, and that it may actually be an indicator of some underlying or overlying attitudes, which might not be very helpful. So I think we need to be mindful of the language and the terms we use. So just drawing your attention to that. And within this heterogeneous group, I think it has been alluded to in previous presentations about migration, about those who come into the UK from abroad and what particular risks or problems they might face. What is it about being an immigrant or being from another nationality in this country which might increase risks to COVID? And even the HSG article refers to people from 23 nationalities amongst the healthcare workers who died. So I think we just also need to keep those people in mind. Apart from BAME, they might also be first and second generation immigrants, and this is referred to in the public health report. Next slide, please. So in terms of understanding the person as a starting point, we were particularly clear on making this point because a risk assessment tool it's been referred to in our document, and it's also mentioned in all other pieces of work which look at how we can reduce risks to BAME staff. But we really wanted to make sure that any risk assessment tools or any conversation was about understanding the person first, about understanding the context. And what I've got here is not an exhaustive list, and it is just an indication really of how we need to be looking at a person as a whole, understanding their cultural, personal identity, their story, their previous experiences, the organizational culture, the setting they work in. I mean, in mental health care, whether it is inpatient, outpatients, forensic, eating disorders, and each settings need a different kind of approach and response. And what their role is within the organization, whether we are talking of trainees, nurses, doctors, allied health professionals. So all these things matter. So it is really understanding and getting down into some detail about the individual behind a label or behind a name, and how those conversations are really important. So looking at their strengths and vulnerabilities, the things that they bring to their role and to their work, and the passion that many people feel for their work really needs to be acknowledged, and how they would like to work if they can safely. And of course, the person's physical and mental health and emotional well-being, and the context in which they live and function. Next slide, please. So we also tried to set out in the report some guidance as to how the known and existing inequalities and inequities might play out in terms of risks in a COVID pandemic in mental health care settings. So I'm not going to read out everything that's written in the report, but the data that's available out there from the Workforce Race Equality Standard, from the GMC Fair to Refer report, which refers to the various inequalities or adversities faced by BAME staff, we've tried to see how they might play out in the workplace setting. So whether it is about those who are more bullied or harassed might find it more difficult to raise concerns about whether those who've been subject to disciplinary processes before might similarly find it more difficult to raise concerns, whether there are more front-facing staff from a BAME background, and whether they might feel less able to ask for the right protections or ask for right mitigations like working from home, etc. So just trying to understand where it is that people are coming from, and organizations and managers being proactive in starting these discussions and in trying to understand the context. So that's mentioned in the report. Next slide, please. And what we've then tried to tease out is what an organizational approach might look like. So apart from that, so that conversation is a starting point, using a risk assessment tool as an aid, not as a checklist, not as a categorical list, and not as an exhaustive list, but as an aid to a structured, sensitive, collaborative conversation about how we can come up with a plan that suits, that mitigation plan that suits that individual. So as part of an organizational approach, firstly, it requires acknowledging it at the highest levels, at board level, and then all the things that need to be put in place, whether it's PPE, whether it's aids for remote working, whether it's working from home, whether it is making sure that there is redeployment if it is required, whether it is looking at how the rotas are decided and who is actually being asked to man those various rotas or be on those various rotas, whether it's providing safe spaces for people to raise concerns and talk about how they're feeling, because what they might be feeling is not a mental health problem but very understandable grief, trauma and distress about what they might be going through, what their families or communities are going through. So providing an enabling safe space to talk is really a very important part of how the organization develops the culture and makes it possible for people to be open. So using staff networks, using things like Balin groups, Schwartz rounds, which we use in our mental health care organizations, having the engagement sessions with board members, senior leaders, all these are part of an organizational approach which would make it easier to identify concerns, raise concerns, understand each person's risks, and then come up with a plan which works for everybody. So it is owned by the organization. It's not, BAME issues are not just for BAME staff alone. They matter to the whole organization because it affects the whole organization. Next slide, please. And so just a point about the risk assessment tool, it's mentioned in the report, but just to say that it is an aid to a conversation and it is not a tick box exercise, an end in itself, or a scoring checklist. And we might have to think about what we call it. There was a discussion about that in our group. So really just being mindful of what the tool entails. Next slide, please. And next slide, this is just how the tool looks and people can have a look at it. Next slide, please. And these last two slides are really about what we can do going forward. So I think, firstly, we need to have accurate data. Lives count and deaths need to count as well. Those deaths should not be in vain. So how we collect data about deaths and how we collect data or record ethnicity on death certificates and about deaths, really important. And Professor Louise Appleby's words come back to me from a webinar yesterday. So in the future, we should have no public database that can't be analyzed by ethnicity. So that's really important, I think. So the learning from deaths has to happen. We need to look at people who've lost their lives and see what it is we can learn from them. Similarly, learn from areas of good practice and using the right language, as I've talked about, and what the college itself can do along, with all the other providers, I think is about provide training to develop and support compassionate, collaborative, and culturally sensitive leadership behaviors. I mean, these are not just for leaders or managers alone, but they are for everybody. But we should enable people to have those difficult and sensitive conversations to make it easier and to understand what we mean by structural racism and underlying factors so that those things can be discussed openly. So I think the college has a role to play in how we train, support, and develop. Next slide, and the last one, please. Thank you. And again, I think, we've said that as a college and we're having this webinar, but I think making the stand against racism and the work to end inequalities and inequities should be a core part of college business across all its various groups and committees. And we need to see how we can hold ourselves to account and give confidence that we're doing what it is that we need to do. Listening to the voices of people, so the active listening and seeing really important and how we capture those narratives. And speaking truth to power, so the Royal College and the organizations in mental health care need to take up place in the national arena, whether it is in the NHS in England, in Wales, Scotland, etc., and make sure that mental health services, patients, and the staff who work in them are counted when we look at mitigating the risks from COVID. Thank you. I would like to end there.
Thank you, Ananta, and thank you for the work that you've done on the task and finish group. We've got 5 minutes now for questions. That seems wholly inadequate, and I'm absolutely convinced from hearing these powerful presentations and the questions that have come in that we are going to need to do at least another webinar on this topic. But we've got just time for 3 questions, probably just 1 to each of the presenters. For those questions that aren't answered, we'll gather them together. We will actually ask the presenters to actually address the issues, and we'll publish the responses on our website. The first question I just wanted to address to Dinesh. Now, Dinesh, we've actually got I think some technical issues with Dinesh's camera, so that's why you can just see his slide. I just want to come to a fundamental question. I wondered if you could address this and fairly briefly if we can. And the question is, I don't think this term BAME is right to use. Collecting all these groups, apart from white British or European people, and labeling them together. I've lost the question, it's moved on. Just doesn't seem right. It seems a label that has just been inflicted upon me by white people. I just wondered, Dinesh, if you could address that fundamental issue of terminology and labeling.
I think that there are major problems in labeling. I mean, we just assume that BAME groups are, as Ananta said, homogeneous. We are not. And even, when you say that, I mean, I think there is a very clear tension that if you meet a European person outside Europe, they never say I'm European, they will say I'm Greek or Croatian or whatever. But we just assume, on the other hand, that all Indians are alike. And that doesn't work, or all Pakistanis are alike, with the differences between Balochistan and Sindh and Punjab are incredibly important personally for identity as well as culture. So I think we need to be sensitive to that rather than using broad brush strokes. There are, for example, I know that there are systems where they use 129 ways of classifying ethnicity. So I think the challenge really is to have a clear debate as to what is it for, why are we doing it, and how do we make sure that the uniqueness of individuals is preserved in that particular context.
Okay, the next question, Abdul, is for you, and it's about the stratifying risk and a proportionate response to that risk. Could you tell us a little bit more about how practically, that for individuals and for organisations, that this can be done?
Yeah, thank you very much for the question. I think primarily, really, that there are a number of ways, really, clearly, that we can embed the vulnerability framework that I've constructed as a conceptual framework. A lot of that, clearly, in terms of our work within Lancashire, is within the risk assessments that we're actually doing around return to COVID secure workplaces, for example, COVID secure schools, in terms of children actually returning, so in terms of educational settings. So, and then the other aspect, really, that we're actually looking at the moment is about the test and trace program. And one of the concerns that I've always had is in relation to the multi-generational households, and in terms of actually increased vulnerability, 3 or more generations actually living under the same roof. And we know that significantly higher as a percentage for the Pakistani and Bangladeshi communities than it is with white Caucasian. So we're talking about tens of thousands of households who potentially, clearly, as we ease lockdown, that clearly there's a risk that the virus, clearly, which is a danger that is still there and is ever present for the foreseeable future, that clearly there will be exposure and clearly impacts as a result of that. So a lot of our work, really, within our local resilience forum within Lancashire in particular, is focusing on appropriate messaging for ethnic minority communities in terms of diversity, and it's actually led by grassroots organisations working with statutory agencies, both within the NHS and out within the local government, working in tandem to actually get that message across in terms of how to actually keep everyone safe and secure. So really, that's hopefully that provides an answer around practical examples around how we're actually putting it into action.
Okay, thanks, thanks, Abdul. And finally, Ananta, this is really about the future and wider issues. What is or will, and I might ask myself, what should the college be doing to tackle structural racism and discrimination in the NHS against BAME staff, e.g. in terms of pay difference, career progression, examination results? And actually, I think we should include the college itself. We should get our own act together from this point of view. What do you think in terms of taking this forward, the broader agenda? What should we be doing?
And I think, as I alluded to very briefly in my presentation, it starts with firstly acknowledging the problem in its entirety and understanding it in its full detail. So I think making a clear statement that discrimination and racism, whatever kind of discrimination, is not acceptable, and that we will be doing everything we can to tackle it, and that it is a part of the core business of the college. It's really important. So it puts it right there in terms of the importance to the college. Secondly, I think it's about having the data. I mean, I mentioned only about ethnicity data in relation to deaths, but I think as a college, we can do a lot more in making sure that we've got the right data in terms of, not just the percentage of overall members who are BAME, but also about their roles, regions, their careers. There's so many things that we can have about our members and about people working in mental health care, which will give us that kind of information as to how, what are the various inequalities and disadvantages that they're facing in their workplace. So collecting the right data, putting it right at the center of college business, acknowledging the problem, and then I think we do need to, if you expect people to be supported within their organizations, we need to play a part as a college in developing the leadership behaviors or the behaviors that will help combat these disadvantages, so that within the organizations that they work in, people are supported, because the college is at one level, but in individual organizations, we need to make sure that people are there who understand what it is that people, the racism and structural racism means, and the inequities mean, and how it is that they can change the culture of their organization and implement those positive behaviors. So I think we have a role to play in developing those behaviors and improving our cultural sensitivity and competency. And I think the whole thing, and again, using the right language matters. So the whole thing comes to almost having a program of our own, where we are looking at how we look at all aspects of racism, the implications on people's lives, careers, and what it is that we can. So it requires a specific identified program of its own in the college, I think, because of the importance it has and the implications it has for services and sustainability and the value that we place on mental health care.
Well, thank you, Ananta. And I wanted to say that I think all those presentations were incredibly powerful and moving, and I think personally upsetting. I find that I'm slightly shaking here, and I know that Ananta, you chaired what was called a task and finish group. Well, it's quite clear there's a huge task, and it certainly isn't finished. And I think, as I said when I put forward my agenda for being president, there is a huge amount of work we could and should do, and I know that there are programs that organizations can follow that are they're right, they're ethically right, but they're good for the organization as well. So this is something that's good for all of us, and that we really need to, and we will. I absolutely give you my word on this, that we will. It will be one of our absolute priorities. But it does need a concerted approach from the top to the bottom of the organization. So again, we've got more questions that we haven't had time to answer. We will actually look at those, and we'll put the answers on the college website. I wanted to thank all of you for giving up your time, for dialing in, for Dinesh, Ananta and Abdul, and also the college team, Katie, Michelle and Isabel, for all that they do. So thank you for joining us, and thank you for all you do, and goodbye from all of us. Thank you.
Thank you.
Thank you.